And I request Dr. Mamta to call the first presenter. Dr. Mamta, please.
There has been a little change in the arrangement. The first presentation will be the fourth one as per the order. It will be by Dr. Nia Narayanan from the Department of Endocrinology. The topic is comparison of insulin resistance and beta cell function in pregnant women with and without gestational diabetes mellitus. So I call upon Dr. Nia Narayanan to start her presentation.
Thank you, ma'am. Can I start sharing my screen, ma'am?
Yeah.
Ma'am, are my screen visible?
Yes, you are visible and audible.
Yeah, thank you. Shall I start?
Yes, please go ahead.
Good afternoon, everybody. I first thank JSS organizing team for giving me this opportunity. I'll be presenting my study will be on comparison of insulin resistance and beta cell function in pregnant women with and without gestational diabetes. This graph depicts the data from the recent ID of diabetes atlas and shows that the prevalence of hyperglycemia in pregnancy is highest among the Southeast Asian countries. It is estimated that every 1 in 6 births will be affected by gestational diabetes. In a normal pregnancy, there is a physiological increase in the insulin resistance, which starts in the second trimester and peaks towards 32 to 38 weeks. To compensate for this, the beta cell has to increase its insulin secretion by 2 to 3-fold. So when this compensation doesn't happen, like if there is a beta cell dysfunction or if there is a pre-gestational pathological insulin resistance, gestational diabetes sets in. In 2009, DeFronzo proposed the concept of ominous octet in the pathogenesis of type 2 diabetes, in that one of the major factors is decreased incretin effect. Incretins are mainly formed by hormones. The major role is by GLP-1 and other hormones like GIP and cholecystokinin. The major function is to increase the beta cell insulin secretion along with other minor roles. So GDM being a pre-diabetic state, there may be a role of incretin dysfunction in its pathogenesis. So which for studies which show which assess the incretin axis in GDM women, we could find only limited studies that too showing discordant results. No such studies was found in Indian population. With this background, we planned an observational cohort study with collaboration with the Department of Obstetrics and Gynecology and Biochemistry. Our primary objective was to evaluate insulin resistance and beta cell function in pregnant women with and without gestation diabetes. And our secondary objective was to compare fetal-maternal outcome in these two groups. We plan to assess the incretin axis by measuring plasma GLP-1 levels and to correlate the beta cell function with the levels. Our screening population were pregnant women in the age group of 18 to 35 years at 24 to 28 weeks gestation. We compared gestational diabetes women diagnosed as per the IADPST criteria with the normoglycemic pregnant women. We excluded women who had pre-gestational diabetes or pre-existing hypertension or who are on long-term corticosteroid therapy or had chronic illness. Even women with multiple gestation were excluded. The women were screened during the routine OGTT, which is a routine test done in our antenatal clinic. Samples for glucose, insulin, and GLP-1 levels were taken at fasting and 30, 60, and 120 minutes after glucose loading. Patient demographics were collected with a structured interviewer-administered questionnaire, and GDM-specific risk factors were assessed. Plasma glucose was measured by hexokinase method, and insulin we used chemiluminescence assay, and for the plasma total GLP-1 we used ELISA kit. Coming to outcome measures, for insulin resistance we measured HOMA2IR, which takes into account, which is calculated by an online calculator and takes into account the fasting insulin and glucose, and is a measure of hepatic insulin resistance. Matsuda index or the insulin sensitivity index is calculated using this formula. It is a better index which shows the whole body insulin sensitivity, and it takes into account the mean glucose and insulin during the whole 2 hours of GTT. For beta cell function indices, we calculated insulinogenic index, IGI, or oral disposition index, and ISSI insulin sensitivity and secretion index 2. For the first two indices, that is IGI and the oral disposition index, takes into account only the glucose and insulin excursion during the first 30 minutes of OGTT, whereas the ISSI2 takes into account the glucose and insulin excursion for the whole 2 hours of GTT, and hence is a better index of beta cell function. We also assessed the feto-maternal outcomes. Sample size was calculated using the this index paper by Ratnagaran et al. And we found a sample size of 20. Expecting a 20% dropout, the sample size was finalized as 25 in each group. Appropriate statistical test was done to analyze the results. We screened 110 pregnant women to get 25 GDM women. And then we selected 25 age-matched controls from the normoglycemic pregnant women. Two control groups, the two women from control groups withdrew the consent after sampling. So finally, we analyzed 25 GDM and 23 normoglycemic women for this table gives the baseline characteristics of the study population. As you can see, the age, gestational age, gravida status, history of GDM in prior pregnancy, hypothyroidism, family history of diabetes, body mass index, BP, TFT, and lipid profile were comparable in both the groups. This line diagram depicts the glucose excursion during the OGTT. As expected, the glucose level was significantly higher in the GDM group at all time points. Now, coming to insulin, as you can see from this line diagram, the insulin peaks later in the GDM group and had a trend towards higher insulin levels at 60 and 120 minutes, though it did not reach statistical significance. Insulin resistant index HOMA2IR, which depicts the hepatic insulin resistance, were comparable in both groups, but Matsuda index, which is a better index and depicts the whole body insulin sensitivity, was significantly lower in the GDM group. All the beta cell function indices like insulinogenic index, oral disposition index, and ISSI2 were significantly low in the GDM group. We did a univariate analysis to look for predictors for insulin resistance and beta cell function in the GDM group. And we found that the body mass index had significantly negative correlation with the beta cell function index ISSI2. Now, coming to incretin axis, we assessed GLP-1. As you can see in the from the line diagram, the GLP-1 levels were low, have a trend towards lower levels at all time points, though it did not reach statistical significance. We analyzed the correlation between the area under curve GLP-1 and the beta cell function indices, and we found that in normal glucose tolerant women, there was a positive correlation between the area under curve GLP-1 level and the beta cell function index ISSI2, but that correlation was lost in the GDM women. Coming to maternal outcomes, the maternal outcomes were comparable in both the group. 1 woman in the GDM group required insulin therapy, rest 24 women were controlled on just diet and lifestyle modification. Average birth weight were comparable in both the groups. One of the neonate in the GDM group had Peary-Robin-Sickens anomaly. All fetal outcomes were comparable in both groups. We reassessed glycemic status of these GDM women after 4 weeks postpartum. We could only trace back to 17 women for 75 gram OGTT after 4 weeks. In that, 3 had persistent dysglycemia and 1 even diagnosed were fitting into the diagnostic criteria of diabetes. Coming to discussion, Matsuda index, which reflects the whole body insulin sensitivity, was significantly low in the GDM population. This was in concordance with the study from other 2 studies from Indian population, that is Nachakar et al. And Graval et al. But the major difference, as you can see, is that our study the mean difference were not as significantly high compared to the other 2 studies available from India. Beta cell functions were significantly low in the GDM group, as was shown in the study by Nachakar et al. This is the only study available which has assessed beta cell function using the gold standard ISSI2. Beta cell function in GDM women negatively correlated with the BMI. There was no significant difference in the GLP-1 levels. This was in contrary to the study by Sukumar et al. From UK, who showed that 12% lower GLP-1 level in GDM women compared to the normal group. However, the Lencioni and Bondi et al. Study, the other 2 studies had similar results like ours, showing no difference. Fetal-maternal outcomes were comparable in both groups. in GDM group, only 32% did not follow up for postpartum OGTT, even after repeated reminders telephonically, and glycemic abnormality persisted in 18%. Our study has major strengths, like the first study in India, which evaluated GLP-1 levels in access in GDM women. And in our study, both groups were equally matched with respect to age, gestation age, gravida status, and BMI. We used OGTT-based indices like Matsuda Index and ISSI2, which are well validated in pregnancy and has good correlation with CLAM studies. Our study had a few limitations, though. We could not use the gold standard CLAM study, and mixed meal test, which was a more physiological stimuli for beta cell function in incretin axis, could not be used. We did not access other incretins like GIP, GLP-2, or cholecystokinin. And also, we could not assess the glucose in insulin dynamics after pregnancy. In conclusion, GDM women have higher insulin resistance and lower beta cell function when compared to women with normal glucose tolerance. Incretin hormones does not play a major role in the pathogenesis of GDM in Indian population, and fetal-maternal outcomes are comparable in both groups. Thank you.
Yeah, thank you very much. Very good study and nicely prepared slides. Just one question. You mentioned those who are on chronic steroid therapy were excluded, but what are the definition you use for that, and what about the people who are on short-term steroids? Will it affect your study?
Yeah. Yes, steroids is likely to affect the insulin and glucagon dynamics of the study. So we did not take any women who were on long-term steroids. Like short-term means whoever had taken that steroids for lung maturity, like 2 doses of betnosol, that patients we had planned to take. But long-term steroid therapy were not taken, sir. But as none of the GDM women required that betnosol therapy. And chronic illness, other like all the chronic diseases like lung diseases, liver diseases, and renal diseases were excluded from the studies. And connective tissue disorders, which is likely to impact the study, we had excluded. Sir.
Okay, we are inviting comments from other faculty or residents. Any faculty from endocrinology here, Dr. Satish or?
Yeah.
Yeah, you have some comments?
Yeah, I think this study is the one which has gone into GLP dynamics. Others have there are studies studying insulin kinetics, but not anything on GLP-1. This is the first study which studies the GLP-1, but we have found it does not have any much role in the GDM pathophysiology.
Anybody has any questions or comments? There is something in the chat box. I'll read it. High BMI was the major predictor of beta cell dysfunction as per your study. Were the dietary habits of participants in 2 groups were compared? Because recent research suggests that people consuming more animal sources of food have a higher risk of obesity.
Yes, sir. Actually, BMI had a negative correlation. Yeah, higher BMI, that is obesity, is a well-known risk factor for beta cell dysfunction. We got similar finding was found from our study, but no, sir, we couldn't do dietary habits because that was not part of our protocol, sir. Maybe next time, if we are planning such a study, we would take into account this also, sir.
Okay, that question was from Dr. Balaji from psychiatry. Please wait for 30 seconds more for any other questions or comments.
Sure, sir.
If there are no questions or comments, thank you, Dr. Nia, for your nice presentation and very clean slides. Thank you very much.
Thank you, sir.
We'll move on to our second presentation of original studies. This is on prognostic significance of T cells and macrophages in tumor microenvironment of nodal DLBCL by Dr. Oncology. So I call upon Dr. Soundarya Ravi to share her presentation.
Yes, ma'am. Are the slides visible, ma'am?
Yes, it is.
Yeah, you are audible and visible. Please proceed.
Yes, sir. Good evening, one and all. So the title of my presentation is Prognostic Significance of T cells and Macrophages in the Tumor Microenvironment of Nodal DLBCL, affiliated to Department of Pathology and Medical Oncology, JIPMA. So revised IPI score is the most common prognostic tool used in DLBCL for risk stratification. However, patients belonging to the same risk category exhibit different clinical outcomes. Recently, the effect of tumor microenvironment on the prognosis of non-Hodgkin lymphoma has been studied. Tumor microenvironment includes innate and adaptive immune cells, which include T regulatory cells, cytotoxic T cells, and macrophages, along with fibroblasts and other stromal cells. So in our study, we aim to identify the association of T regulatory cells, cytotoxic T cells, and macrophages with immunophenotypes, clinicopathological characteristics, treatment response, and survival. So the study was initiated after obtaining clearance from the Institute Ethics Committee, and the total number of cases included in our study was 83. So the clinical and treatment details were collected from the medical records. DLBCL was immunophenotyped into germinal center and activated B cell type by Hans algorithm. CD8, FOXP3 and CD68 immunostains were performed on the biopsies to highlight the cytotoxic T cells, T regulatory cells, and the macrophages respectively. These patients were followed up to June 2020 with a median follow-up time of 23 months. The overall survival and progression-free survival were calculated. So, the number of cells in the immune microenvironment were counted in 10 hypo field of maximum density by 2 individual pathologists, and the average value was taken as the final value. The association between the cells of the tumor microenvironment and the immunophenotype and clinicopathological characteristics was done using independent student t-test. The independent predictor of response to treatment was identified by binary logistic regression. Survival analysis was done by using Kaplan-Meier and multivariate Cox regression analysis. So coming to the results, in our study group, the median age was 55 years, ranging from 14 to 80 years, with a male to female ratio of 2.1:1. In our study group, the most common immunophenotype was the activated B cell subtype, comprising of 63%. Out of these 83 patients, 76 patients received chemotherapy, out of which 53 patients completed 6 cycles of chemotherapy. They were subjected to response assessment by Chesson criteria, out of which 38 patients attained complete response to treatment. 15 patients had either partial remission, stable disease, or progressive disease. They were all clubbed into a single group for statistical convenience. This is an example to show the DLBCL germinal center subtype, which was positive for CD10 and BCL6 with the corresponding markers of the microenvironment. This is an example for DLBCL activated B cell subtype, which was positive for MUM1 and with the corresponding immunophenotypic markers of microenvironment. So this is a table to show the clinicopathological characteristics. These symptoms were present in 54% of the patients. Advanced clinical stage was present in 59% of the patients. Bone marrow infiltration was present in 13% of the patients. This is a table to show the association of tumor microenvironment with the clinicopathological data. It can be observed that there was a significant decrease in CD3 and CD8 positive T cells in patients more than 60 years, which could be attributed to the fact that there is a decrease in T cell mediated immunity with increasing age. There is no significant association between the immune microenvironment and the immunophenotypic group. This table, we can observe that there is a significant increase in the macrophages in patients having early clinical stage. So this is a table to show the association of tumor microenvironment with the treatment response. There is a significantly higher number of CD3 and CD8 positive T cells in the complete response group when compared to the less than complete response group. So as the association was significant, cutoff values for CD3 and CD8 were derived using ROC curve. The optimal cutoff for CD3 was 34.5 and for CD8 was 6.5. And the patients were divided into two groups, and it was compared with the treatment outcome using chi-square test. So the chances of attaining complete response to treatment was significantly higher in patients having CD3 more than 34.5%, CD8 more than 6.5%, and patients with good prognostic group. Also, by binary logistic regression analysis, we could find out that patients having CD8 more than 6.5% was an independent predictor of treatment outcome. Coming to the follow-up statistics, among all the clinicopathological characteristics, RIPI score had a significant effect on survival, which could be seen from this Kaplan-Meier graph that patients with good RIPI score had a significantly better progression-free survival and overall survival when compared to patients having poor RIPI group. This is a table to show the effect of tumor microenvironment on the survival. It can be seen that higher number of CD68 positive macrophages had a significant association with the better overall survival. A multivariate Cox regression analysis was done, which showed that cases with good RIPI prognostic score had 72% reduction in risk of death when compared to patients with poor RIPI score. Also, there was a 5.5% reduction in the risk of death for every 1% rise in the background CD68 positive macrophages. Coming to discussion, among all the clinicopathological characteristics, only RIPI score had a significant association with treatment outcome, overall survival, and progression-free survival, which was concordant with Galilei et al. Study. In our study, high CD8 positive T cells, more than 6.5%, correlated better with the complete response to treatment, which was concordant with Lipman et al., where in his study he had used LEU2 as the immunostain and obtained a similar cutoff of 6%. So our study indicates that cytotoxic T cells have a crucial role in anti-tumor immunity in DLBCL by inducing apoptosis in the tumor cells. Also, high expression of CD68 positive macrophages in the microenvironment had a significant association with the overall survival, which was concordant with Nam et al. And Rihijarvi et al. However, many recent studies have shown that M2 macrophages, which are CD163 positive, correlated with poor overall survival and progression-free survival. In our study, T regulatory cells did not have any effect on the treatment outcome nor the survival, which was concordant with Hasselblom et al. So the utility of our study is that CD8 and CD68 could be implemented in the routine immunohistochemical panel to obtain additional prognostic information about the patient. The limitation of our study was the true cut biopsies could not represent the true value of the microenvironment of the whole lymph node. Manual counting decreased the objectivity of the study, and we had a shorter follow-up period. So in conclusion, I would like to say that RIPI score remains to be the best prognostic tool for risk assessment of DLBCL. Higher number of T cells, especially cytotoxic T cells, were associated with better complete response. CD8 more than 6.5 proved to be an independent predictor of treatment outcome. And finally, high CD68 positive macrophages in the tumor microenvironment correlated significantly with better overall survival, thus proving that macrophages also have an anti-tumor effect. These are my references, and thank you for providing this opportunity to present in JSS. Thank you.
Yeah, thank you very much. You mentioned a good presentation. You mentioned the true cut biopsy is not enough. Okay, so what are you suggesting? You're not suggested anything. You want a excision biopsy?
Yes, sir. Actually, true cut biopsy just represents a part of the lymph node. So even when we obtain excision biopsies, there might be areas which might have more number of immune cells, and there might be having areas with having less number of immune cells. Suppose if the true cut was taken from that part, it would not be able to represent the entire lymph node. So an excision would be better when compared to true cut, sir.
Okay.
Sir, can I add one more point?
Yeah, please.
I'm Dr. Srirekha, sir.
Yeah, please.
True cut biopsies for lymphoma diagnosis are usually done when the lymph nodes are intra-abdominal or mediastinal lymph nodes, which are not accessible to take a full lymph node out. So in those cases, even for diagnostic purpose, there will be some problems, let alone for this study per se. But usually when it is a peripheral lymph node enlargement, usually we advise the full excision of the lymph node for diagnostic purpose also, sir.
Okay, okay. We are inviting comments and suggestions from other faculty or residents. Dr. Sandhya, just please wait for around 30 seconds.
Sure, sir.
Yeah. If there are no further questions, thank you very much for the nice presentation and new finding. Thank you very much.
Thank you, sir. Thank you.
Thank you.
We'll move on to the next presentation. This is titled Hunger-Based versus Conventional Overfeeding in Moderate and Severe Acute Pancreatitis, a randomized controlled trial by Dr. Guru Shankari B. from the Department of Surgery. Dr. Guru Shankari, you can share this presentation, please.
Yeah, please make it full screen. Yeah.
You can start.
Yeah, please start your presentation. You are not audible.
Can you hear us? She's muted.
Can you hear me, ma'am? Can you hear me, ma'am?
Can you hear us?
Yeah,
Yes,
you're
sir.
audible.
Yeah, you are audible. Your slides are not visible. Yeah, now it is visible. Please proceed.
Good afternoon, all. I'm here to present a paper titled Hunger-Based versus Conventional Oral Feeding in Moderate and Severe Acute Pancreatitis, a randomized controlled trial. Before we go further, let's look into some numbers in pancreatitis. The global incidence of pancreatitis is 4.9 to 73.4 per 1 lakh population worldwide. The mortality of infected pancreatic necrosis is 50%, and 33% of the population develop pancreatic infection in the first 24 hours and 75% in the next 48 to 96 hours. Systemic inflammatory and septic complication ranges from 40 to 50% in moderately severe and severe acute pancreatitis with a mortality of 30%. The mortality in severe acute pancreatitis ranges from 10 to 30%. So how do we reduce this number? Nutrition. Nutrition is a cornerstone in management of any surgical illnesses, and it is the key stone in the management of acute pancreatitis. A dysfunctional gut barrier leads to infective complications, which initiates the cascade of inflammatory responses leading to multi-organ failure. In the early phase of pancreatitis, the major mortality is because of multi-organ failure, and septic complication are the causes of mortality in the late phase. Thus, maintenance of gut barrier integrity forms a major goal in the early phase management. It is achieved by means of enteral nutrition, which prevents the atrophic changes in the gut lining, prevents intestinal bacterial overload, and increased gut permeability. According to the conventional management protocols, in an acute stage of pancreatitis, bowel rest becomes the ideal treatment. But recent researchers have shown that diet restriction can lead to negative energy balance and exacerbate the inflammatory response leading to catabolism. Early feeding decreased the length of hospital stay without increasing the incidence of feed tolerance in recent researches. Nasogastric tube feeding and soft diet has been tried in moderate acute pancreatitis. Hunger-based oral feeding is an emerging concept which is based on the fact that hunger reflects the recovery of GIT. However, to the best of our knowledge, there are no RCTs or large trial based on this emerging concept. An RCT with limited number has tried the beneficial effect of hunger-based feeding in moderate and severe acute pancreatitis. The aim of this study was to determine the efficacy of hunger-based oral feed versus conventional oral feed in patients with moderately severe and severe acute pancreatitis, with a primary objective to compare the length of hospitalization between the two groups. The study design was a parallel arm superiority randomized control trial conducted in November 2017 to December 2019 at JIPMER Puducherry, approved by the Ethics Committee and registered in the Clinical Trial Registry of India. More than and equal to 18 years with a moderately severe and severe acute pancreatitis based on modified Atlanta classification 2012 were included in this study. Patients who had a non-conventional or a rare cause of pancreatitis were excluded from this study to maintain a homogeneous population, and patients who had a confounders which can lead to prolonged hospitalization such as shock, intubated patients were excluded from this study. In patients whom the intervention could not be carried out, such as nasojejunal tube insert, were also excluded from this study. It was stratified permuted block randomization using randomly selected block size of 4 and 6. The patients were randomized into hunger-based feed group and conventional feed group. Allocation concealment was done with the help of snooze technique, and the principal assessor was blinded to the intervention. So how did we carry out this study? In HBF group, the oral feeding was commenced once the patient felt hungry and the tolerance for feed was assessed. Regardless of abdominal pain, laboratory parameters, and the feeds were gradually escalated to clear liquid, semi-solids, and solid feeds. Once a feed intolerance arises, it was withdrawn and it was again restarted when the patient felt hungry. In CF group, the oral feeding was commenced according to the conventional standard protocol, which says that oral feeds has to be started once the abdominal pain reduces, vomiting and nausea resolves, and the feeds were gradually escalated to clear liquid, semi-solid, solid feeds, and the tolerance for feed was observed. Patients in both the groups were followed up till their discharge. The primary outcome was length of hospital stay. The secondary outcome were reduction in the fasting duration, feed intolerance, morbidities, invasive non-surgical procedures. Sorry for the busy slide. These definitions were used in this study. The fasting duration was defined as day of onset of abdominal pain till the day when oral feed resumed. Feed intolerance is occurrence of pain abdomen, nausea, vomiting, or abdominal distension after the first feed. Morbidities such as sepsis, infected pancreatic collection, etc. were included. Invasive non-surgical procedures such as aspiration of acute peripancreatic fluid collection, walled-off necrosis, pigtail placements were also included. The sample size was according to the expected difference of 2 days in hospital stay between the two groups for 56, and according to the OpenEpi software calculated as 65 with a confidence interval of 95%, power of 90%, and loss of to follow up as 10%. All statistical analysis was performed in SPSS version 19. The descriptive statistics such as frequencies, proportions, and percentage of categorical and continuous variables were expressed in terms of mean, standard deviation, and median. The inferential statistics such as proportion, chi-square, and Fisher-Exact test was used, and for mean difference, it was independent t-test. A modified intention to treat analysis was performed with a 95% confidence interval and power of 90, p-value less than 0.05 was significant. This is a consort diagram for the study. Around 198 patients were eligible for this study and 81 was excluded because they didn't meet the inclusion criteria or they declined consent. Around 117 patients were randomized into HBF and conventional group. There was no loss to follow up in both the groups, and 3 in HBF and 4 in conventional group did not receive the intended intervention. Around 56 in HBF group and 54 in conventional feeding group were analyzed using modified intention to treat analysis. So let's move on to results. The demographic details and the clinical characteristics were similar across the groups with a minimal difference in the number of male patients across the groups. When the primary outcome parameter was assessed, the mean length of hospitalization was significantly lower in hunger-based feeding when compared to conventional feeding, with a mean difference of 1.04 days. And the mean fasting duration was lesser in HBF group. When the secondary outcome parameter was assessed, feed intolerance was similar among both the groups. Comparison of various infective morbidities such as infected pancreatic collection, necrosis, sepsis, etc. was compared. It was similar across the group. Similarly, comparison of invasive procedures such as aspiration, pigtail placement, pleural fluid aspiration was similar across the group. The strength of the study is it is a novel study as it has been conducted for the first time in the moderate and severe acute pancreatitis. The sample size was adequate and was achieved. The limitation of this study is we couldn't give a specialized diet such as low fat diet and probiotics for these patients, and it was a single blinded study, which was an inherent limitation of this study as the patient could not be blinded for the intervention. So, hunger-based feeding in moderate and severe acute pancreatitis decreased the length of hospitalization and fasting duration without any rise in the feed intolerance or infective and septic complications or invasive non-surgical procedures. A feasible and safe method based on hunger, not dependent on any resolution of clinical and laboratory parameters, reduced the length of hospital stay without rise in septic complications and invasive procedures. So, hunger-based feeding as a standard of care, is it time to change practice? Thank you for your kind attention. Thank you for giving me this opportunity.
Yeah, thank you for the nice study and nice presentation. Just I have one question to ask. You mentioned that median hospital stay was 6 and 7 days, correct?
Yes, sir.
Somewhere between. So, is it because normally we expect a long hospital stay in severe acute pancreatitis, those who require admission? Is it because of the moderately severe group dominates the study? What is the proportion of moderately severe and severe in this study?
So, in this study, we have included only moderately severe and severe pancreatitis. We have not included mild pancreatitis patients.
How many of them were moderately severe? How many of them was?
They were all, since it's a randomized, most of them like equally distributed.
Okay. So my suggestion, when you publish, please look into that aspect as well.
Yes.
Because normally you expect more than 10 days in the hospital stay in severe acute pancreatitis. We invite questions and comments and suggestions from other faculty and residents.
Hi, I'm Dr. Bala from Biochemistry. I have a question that you have used two forms, hunger-based feeding and conventional feeding. And have you measured any biochemical parameters saying that this hunger-based feeding reduces this acute pancreatitis?
No, sir. We have not assessed any biochemical parameters. We have only seen the length of hospitalization and the secondary outcomes such as feed intolerance, fasting duration.
So how come we can come to a conclusion that it reduces hospital stay? What are the mechanisms behind that?
So, actually, hunger is a strong feeling. Patients who's not well, even though they have clinically abdominal pain or the amylase and lipase values are elevated, when a patient feels hunger, that means that the GIT is in the recovery phase. So based on this concept, we have started diet on this patient, not giving on the clinical symptoms or lab parameters because it can take some time for them to resolve. So based on this concept, we have started, and enteral nutrition is an important component in any surgical patients because it really improves their nutrition and decreases the complications.
So what about any histological observation? So whether this for those patients?
I didn't get you, sir.
No, any histological observation after hunger-based feeding?
Histological.
Yeah, inflammation,
No,
to assess whether it's reduced inflammation. following your hunger-based therapy?
Not part of our outcome parameters, so we have not assessed for any increase in inflammation based on histology or any radiological evidence.
All right. Okay. Thank you.
Yeah, please wait for another 30 seconds for any other comments or suggestions.
Yes.
Yeah, if there are no further questions, thank you very much for the nice and good percentage, especially a randomized trial. We promote more randomized trials for JSS. Thank you very much.
Thank you, sir.
Thank you.
We move upon to the next presentation by Dr. Remy Ramakan from the Department of Transfusion Medicine. The topic of this study is prevalence of dengue NS1 antigenemia among healthy blood donors in a tertiary care center in southern India. Dr. Remy Ramakan, can you please share your slides?
Yeah, Dr. Remy, you are not audible.
Sir, am I audible?
Yeah. Yes. Your presentation is visible. Please proceed.
Okay, sir. Thank you, sir. Good afternoon, everyone. So I'm Dr. Remy Ramakan from the Department of Transfusion Medicine. I'm really honored and pleased to be presenting this topic in front of you all. So my study was on prevalence of dengue NS1 antigenemia among healthy blood donors in a tertiary care hospital in southern India. So in a developing nation like India, dengue transmitted via blood transfusion is still not a problem to reckon with. So this is mainly due to poor awareness regarding such a route of transmission of dengue among the donor population. But transmission of dengue by transfusion of blood products is documented in the literature. But what is the frequency of these occurrences and what is the level of viremia required to cause such a clinical dengue, it is still unknown. So dengue has a viremic phase of 4 to 8 days, but the interesting fact is that in this viremic phase, both symptomatic and asymptomatic individuals can act as potential vehicles for transmission of dengue while going through blood donation. So viremia usually precedes the onset of symptoms. So what is the rationale behind us taking dengue NS1 antigen instead of IgM or IgG? That is because in transfusion transmitted dengue, dengue NS1 antigenemia is the one which is implicated. So currently, rate of transmission of dengue via blood donation is rising at a steady speed because 2.5 billion population is already residing in dengue endemic regions. So as of now in India, dengue screening is not mandatory. So in order to implement any donor screening for dengue, it is only logical that we do a systematic study like ours so that we can evaluate what exactly is the threat that dengue infection actually poses via blood transfusions. So novelty of our study is novel due to its large number of donors who were tested, and it was done for a period of 1 year and not just restricted to testing during the dengue peak seasons, which was done in other studies. Also, such a study could be of great help in measuring the magnitude of dengue infection among the donor population rather than the general population. Also, it would help in future implementation of any kind of dengue screening, vaccination policies, or even to implement other control measures like pathogen inactivation techniques. So what were the expected outcomes from our study? So we thought that our study would give an insight into whether dengue screening has to be implemented along with our other routine TTA screening, and if at all we implemented, how much is it feasible in a setup like ours, and what are the outcomes? It would also throw light on the seroepidemiology of dengue virus infection among the blood donor population coming to our institute. So our primary objective obviously was to determine the prevalence of dengue NS1 antigenemia among the healthy blood donors coming to our institute. Secondary objectives were to assess whether such a dengue screening in the donor population is actually feasible or not. And also, if possible, to assess the seasonal trend of the dengue infection. So it was a cross-sectional study. It was done for a period of 1 year, and we have selected all blood donors according to the guidelines provided by Government of India and our departmental SOP. So we have excluded all the TTA reactive samples, lyse samples, deteriorated samples, and insufficient samples. So how did we calculate the sample size? Using the Daniels formula, assuming a prevalence of 1.5% for dengue and relative precision 50%, the sample calculation came to 880. But then we had to also consider 10% extra for wastage and standardization of ELISA kits. So the end sample size came to 968. So how did we do this? So 3 samples were chosen daily for 5 days in a week. So for de-identification purpose, we had our counselor who sits in the donor screening area. So she would ask any 3 donors per day to fill 2 donor questionnaire forms. So one form would have all the personal identifiers of the donor, and the other one without any personal identifiers would be assigned a number, and the same number would be assigned to the sample from the donor also. So once the TT testing was all over, the same samples would be handed over to the investigator by the TTA technician. So how to interpret the ELISA results? So for that, we need to first of all calculate the cutoff value. So cutoff value is calculated by taking the average value of the negative controls and then adding 0.3 to it. So we got the cutoff value. Now the samples with an absorbance value less than the cutoff value, they would be considered non-reactive. And the samples with the absorbance value equal to or more than cutoff value were considered reactive. So the categorical data like age, gender, etc. in our study were all expressed as frequencies and percentages, and all statistical analysis was carried out at 5% level of significance, and p-values less than 0.05 were considered significant. So coming to the results of my study, 96% of the total donors were males, and 448 of our donors, that is to say 46% of the total donor population which were tested. So they belong to the age group 18 to 24 years, followed by 349 donors who belong to the age group of 25 to 34 years. So 66% of our donors were all from rural areas. So this is an interesting finding where 47% of our donors were all graduates, followed by diploma holders, and at least most of our donors had primary education. Only 0.8% of our donors were illiterate. So coming to the occupational categories of our donors, 38.7% of them were unemployed. That is to say, most of them were students. So that is why they came in this category of unemployed. And 55.5% of our donors were donating blood for the first time. So 44.5% of the rest of the donors, they were repeat donors. That is to say, they have at least donated once. 563 out of the 960 donor samples which were tested, so 563 of the donors were voluntary donors. Now, this was the end result of our dengue NS1 ELISA testing, where we had tested 960 donor samples and we got 9 reactive samples out of it. That is to say, 0.9% of the donor samples were reactive or positive for dengue NS1 antigen in them. So this is the month-wise distribution of various reactive samples. So this is the distribution of reactive donors. So the areas where they belong to in Pondicherry. So this is the table showing all the reactive donor variables. So you can see that 3 of the reactive donors, they were in the month of December. They actually donated in the month of December, 2 in the month of January, 1 each in February, April, May, and October. So you can't really point out a seasonal trend over here. But Pondicherry being endemic for dengue, we can say that irrespective of the seasonal variation, dengue cases can come up anytime. And we can see that except one donor, all the donors were replacement donors who were donating blood for their relatives who were admitted in JIPMER. And also except 2 reactive donors, all the other reactive donors were all donating blood for the first time. So coming to the discussion part, 70% of the dengue virus can actually persist in the donor blood for about 7 days, especially in the acute phase, when they would be asymptomatic, and that is why they come to our blood bank for blood donation. So many of the emerging pathogens they present in an asymptomatic form in the healthy individuals, while they'll be clinically evident more in the patient population. So we got a 0.9% seroprevalence for dengue NS1 antigen among our donor population, which was similar to the study done by Ashish Jain and colleagues. Especially this study was done in AIIMS Rishikesh, where they found 0.54% seroprevalence for dengue NS1 antigen in those North Indian donors. But the only other two studies conducted in India, in New Delhi and Chennai, they didn't show any seropositivity for dengue NS1 antigen among their donor population. So this is a summary of all the studies that I reviewed. So where we can see that this study by Ashish Jain with a donor population of 369 showed a seropositivity for dengue NS1 antigen as 0.54%, while the studies done by Sadhana Mangwana and Chitra and others in New Delhi and Chennai showed no seropositivity for dengue NS1 antigen in their donor population. And in the international studies, we can see that this particular study done in Saudi Arabia, in a donor population of 100 donors, they found 1% seroprevalence for dengue NS1 antigen. So in India, the problem is that usually the focus is on vector spread dengue rather than dengue spread via blood products. Also, in many studies, it is shown that the highest seroprevalence of dengue is actually found in the southern parts of India, amounting to 77%. So this study all the more gains importance, especially because it was reported that in the years between 1998 and 2014, the highest incidence of dengue actually was from Pondicherry. So as I mentioned, we couldn't establish any seasonal trend in our study. Strengths of the study, the large number of donor samples that we tested for dengue NS1 antigen, and also the reason that we use dengue NS1 antigen all the more adds value to our study, because in the asymptomatic phase, the donors would be having dengue NS1 antigen in their serum. Limitations of the study would be we randomly selected the donors, so maybe we would have missed some of the other reactive donors. Also, the reactive samples, we never repeated it again with more sensitive methods like RT-PCR. Also, we couldn't follow up the donors and recipients who received the reactive bags. So the future direction should actually focus on prospective evaluation of NS1 antigen in all the asymptomatic donors coming to our blood bank. And also we can also adopt some advanced assays like RT-PCR in future studies. And also we should also explore the application of other techniques like pathogen inactivation in order to inactivate viruses like dengue if at all the blood products are infected. So to conclude, we got an overall seroprevalence NS1 antigenemia in the healthy donors as 0.9% out of the total 968 blood donor samples that were tested. So this is a considerable proportion of population. This shows that a considerable proportion of the population in the southern parts of India being asymptomatic dengue virus carriers. So in the future, the studies can actually focus on following up the donors as well as the transfusion individuals so that we can actually quantify what exactly is the risk of transfusion transmitted dengue in the recipient population. So that's all. Thank you for your patience. Thank you, everyone.
Thank you for the nice presentation. And I have one clarification to ask. Some of the screening tests you do has a much less seroprevalence. Okay, this is 0.9%.
Yes,
so
sir.
What let us say HIV, HPV and other things. So what position you will take? You advocating testing or not testing?
Sir,
and what is logic behind that decision now? Because now you have the fact with you.
Yes, sir.
You know that some of the screening tests you do may have a lesser seroprevalence.
Sir, the thing is that rather than looking upon the prevalence in the donors, we should actually look on studies on the transfusion transmitted dengue in the recipient population. Because donors are fine, they are asymptomatic, and if we follow up also, they would be having, like, they would recover because they are healthy individuals. But in the recipient population, because only case reports are there, because in 2002 in Hong Kong, it was the first reporting of transfusion transmitted dengue. It was reported in Hong Kong. So after that in Singapore, Brazil, Puerto Rico and all. But other than that, what is the prevalence in the recipient population, that is still unknown. So unless we know the risk of dengue transmitted via blood products, we cannot actually comment upon starting a new screening for dengue in our donor population. It's not feasible also. But then when it comes to cost, especially in our institute, maybe I can say that it's feasible because it would cost around 90 rupees per test, because we already have ELISA machine, ELISA reader, we have everything, even the consumables. We don't have to buy anything from outside. Only the particular test, dengue NS1 test or the kit needs to be purchased. So each test for each donor would only cost around 90 rupees. So it's feasible to do in a setup like ours, but not everywhere else.
Dr. Ravi, what was the stand taken by transfusion medicine department during the study? If the donor tested positive, were you releasing the blood for transfusion or you were withholding it?
And the thing was that why we couldn't even follow up the donors was that usually what happens is that in a single ELISA plate, if I load, there would be 92 wells. So I need to get at least 80 to 90 samples to run a plate, so that it doesn't interfere with the routine work also, because the routine TTA workup would be running in our department. So I have to do this separately. So I would wait for 80 samples in a month, in a month, and then I would do. So what I used to do is I used to collect these samples, I would freeze it in the deep freezer, the serum alone, and then at the end when I get 80 plus or more samples, then I would do the test. So what happened at that time is that by that time, if at all, only at the end of the month, I would come to know that I've got some reactive samples. By that time, definitely our blood products would have been issued, transfused. So there was no way that I could follow up, especially when the samples were actually de-identified too. But there was a way, maybe after 1 month or so, I could have followed it up. But then 1 or 2 I tried, but then even the residents who are in charge of the patients, even they wouldn't remember, and it is really tedious for them to find out what bag was transfused to which patient and so on. So that was the problem, ma'am.
Any faculty from transfusion medicine want to comment? Any other comments from faculty or residents?
Sir, actually, that 9 patients, what you have done, that positivity turned, whether you followed up, whether they manifested any clinical symptoms, those 9 patients out of 968 who turned positive, because you told that, that viremia is for 4 to 8 days. Are you able to follow up? Because that is very important. Then only we can determine that whether that is like significantly causing any problem or not in that, because you told you are not able to prevent the means the issuing the blood for somebody, isn't it? So
Yes,
what is the follow? I think you can follow very well.
Sir, 3 to 4.
The follow up of the patients.
Sir, only for 3 to 4 patients, sir. I had to contact the resident in charge of those patients. I had to see my register to which patient the particular numbered bag went to, and then I called up the resident. But according to them, hardly, luckily or unluckily, but the patients who got transfused by those bags, I only followed up 3 to 4, and to whomsoever I called and asked regarding the patient status, either they were discharged or they didn't have any kind of symptoms due to transfusion as such. So dengue.
No, I'm not talking about the recipient. The donor who are positive 9 patients, 9 donors, whether
Sir,
they have manifested any clinical features of dengue or not.
No, sir,
Because
no.
they were in asymptomatic phase, whether they have followed, whether platelet, no, you could not follow.
Only 9 reactive donors, and I had called them because in our donor questionnaire we have their phone numbers and everything. I called them up, and none of them had any manifestation of dengue as such. They didn't even manifest actually any symptoms.
So what is the position?
Yes, sir. Sorry, sir.
So what is
Sir.
able
Sir,
to hear?
currently in
Yeah,
India, screening for dengue is not mandatory by law. So because India as such, in every part, it's endemic for dengue. So according to our government guidelines, screening for dengue is not mandatory as of now. But there are other countries where dengue screening is going on?
Okay.
Yes,
So
sir.
whether then it will be a prudent to screen all the donors for dengue. Is it mandatory or not? Whether it is a cost effective or not? You please let me know. Because
Yes,
it's
sir.
maybe study purpose, whether it is a cost, because HIV is causing significant disease, hepatitis B is causing, hepatitis C is causing, all those transmission infection is causing significant disease. In that scenario, because dengue, you told it is India is endemic for dengue. Everywhere the Aedes mosquito is there. In that scenario, whether it is cost effective to screen everybody to detect less than 1% of the dengue transmission in this transmission means in the cost cutting measures and whatever thing.
In a tertiary care center like us, it is definitely cost effective. As I mentioned earlier, it hardly costs 90 rupees per test. Because everything else we have in our department. Like let it be the ELISA machine, let it be the consumables, let it be anything what you require for doing a ELISA. I'm not talking about RT-PCR. So for ELISA, we have everything. So I'm sure that other tertiary care centers, since they also do TTA screening for HIV, HBsAg, HCV, it is imperative that definitely they'll be having all these machines and everything. So only the patient would have to spend 90 rupees for that particular test. Only one test for the dengue NS1 antigen detection. So that can be done, sir. It is cost effective. For a setup like us, it's definitely cost effective to do for every donor.
Have you done IgM or IgG antibody for those patients?
We haven't done, sir.
IgM, IgG antibody, not done. Na?
Not done, sir, because we only focus on the asymptomatic donors, sir. So usually asymptomatic donors means they are still in the viremic phase. So no point in doing IgG or IgM because IgM takes around 10-12 days to develop, especially after the symptoms manifest. That is when they develop.
Okay.
Thank you, sir.
Are there any other comments or suggestions? Yeah, Dr. Ami, what probably what the comments are about, since it's a notifiable disease.
Yes, sir.
The dengue is a notifiable disease. Sitting on a data and with the information of the patients, we have to be ethically very take a clear stand about that. What we have to do with that patients, whether we have to notify. Second, when you publish also, definitely there will be. It's better that you take this paper to the ethics committee once again before if you want to publish it and go through that, and you will be otherwise by the reviewers you will be asked to take a stand on this. This question will definitely come from the reviewer.
Yes, sir. Definitely, sir. And we have still some of the kits left. So I was planning that if at all, because this is the peak season for dengue. So if we can actually follow up some of the patients, it would be great.
Okay, thank you very much for the nice and elaborative presentation.
Thank you, sir.
Yeah, thank you very much.
We move on to our next section on presentations on case reports. The first one will be on acromegaly incidentally diagnosed at term in a pregnant woman presenting with ventricular premature complexes by Dr. Aishwarya Nair from the Department of Obstetrics. Dr. Aishwarya, can you please share the screen and present?
Please share your screen.
Share your slides, Aishwarya. Yeah, it's visible.
Yeah, please proceed. You are not audible. Please unmute yourself.
Good afternoon, everyone. Am I audible?
Yes, you are audible and visible also, so you can proceed.
Thank you. Good afternoon, everyone. I'm Dr. Aishwarya Pinayat. I'm from the Department of Obstetrics and Gynecology. Today, I'm presenting a case report on acromegaly, incidentally diagnosed at term in a pregnant woman who presented with ventricular premenstrual complex. My co-authors are Dr. Harita Sachili, Dr. Jailakshmi, and Dr. Parvati from the Department of Obstetrics and Gynecology.
Aishwarya, your audio is not clear. Can you remove the mask and speak?
Yes.
Yeah, please proceed.
Acromegaly has an annual incidence. Thank you, sir. Acromegaly has an annual incidence between 0.2 and 1.1 cases per 1 lakh population. Pregnancy in acromegaly, pregnancy in women with acromegaly are rare condition. Usually, because of pituitary adenomas, which have a completely effect on the pituitary stalk, there will be gonadotropin suppression and generally the infertility in women who have acromegaly. The diagnosis in pregnancy of infants and limited literature is available. Here we report the case of acromegaly incidentally diagnosed in a pregnant woman who presented a term with ventricular premature complexes on ECG. Coming to the history, she was a 31-year-old primary gravida who had primary infertility for 10 years and conceived on second cycle of ovulation induction. She came at 37 weeks of gestation with breathlessness and palpitation. There was no history of fever, chest pain, hemoptysis, skin cough, or any cough. She was in all case of gestational hypertension. She was diagnosed at 32 weeks and she was on Glabetron 100 mg 12 hourly for the same. There was no other significant past medical or surgical history. She had no significant family history. She was referred to JIPMER with the complaint of breathlessness and palpitation, along with altered ECG showing ventricular premature complex. On the ECG had a BPC syndrome, and on examination, patient had coarse facial features with unusually thick and full lips, and there was a feature of prognatism, large trunk, enlarged hands and feet. Coming to systemic examination, coming to general examination, there was no palate. BP was 130/70. She was maintaining saturation of 90% at room end. Her pulse rate was 90 per minute. The rhythm was regular. Breast and thyroid examination was normal. Both CVS and RS examination was normal. Neurological examination was also normal. Her abdomen, she had uterus with term size, phallic presentation with adequate right step and good fetal heartbeat. Based on the ECG finding of BPCs, further investigations were carried out. Echo showed mildly dilated left atrium and left ventricle with mild MR and AR with normal LV systolic function. Chest X-ray was normal. COVID testing was normal. All blood investigations were normal except for hypokalemia. She had hypokalemia of 2 to 2.75 milliequivalents per liter, but her 24-hour urinary potassium excretion was normal. Other than this, all her hemogram, LFT, renal function tests, thyroid levels, oral glucose tolerance test, and cortisol levels were also normal. Visual field testing was done, it is normal. Fundus examination was also normal, there is no sense of pathology. Based on the appearance of the patient with a history of hypertension, hyperkalemia, and the history of infertility, a diagnosis of pituitary adenoma, which is causing acromegaly, was expected. And based on this, an MRI scan was done. In MRI, there was a faint hypoenhancing lesion of size 7 to 8 millimeters square in the right anterior pituitary, which is suggestive of pituitary microadenoma. So the diagnosis of a pituitary adenoma causing acromegaly was made in the patient. And as per the endocrinology opinion, she was planned on conservative approach. As her hormone profile was normal, it is considered as a non-functioning microadenoma. And hypokalemia was corrected, with which the BPC also subsided. Neurosurgery review was taken, and surgical intervention was not required at that time. From obstetric side, she was planned for elective LFTs and a combined spinal epidural anesthesia. The elective LFTs was considered because of an intracranial tumor and the use of Valsalva manual, which is involved in normal delivery, was contradictory. It was a precious pregnancy with 11 years of infertility, and the baby was estimated to be of around 4 kg weight and very big baby. Hence, an elective LFTs was considered, and baby was delivered at term alive 3.7 kg and there were no perioperative complications. Fortunately, her BP was stabilized and drugs were discontinued, and she was discharged on post-operative day 4. The in-hospital course was uneventful. She was planned for a complete endocrinology evaluation at 3 months postpartum. Our patient was incidentally diagnosed with acromegaly when she presented at term gestation with ventricular premature complexes. There has been no such report of a pregnant patient presenting with BPC in acromegaly previously. Other than that, she had history of infertility and hypertension, which are common manifestations in acromegaly. Other features like gestational diabetes, vision disturbances, and the hypertrophic cardiomyopathy, which are usually seen in acromegaly, was not seen in our case. Hormonal assessment for the diagnosis of acromegaly is challenging in pregnancy because there is interference between pituitary hormones and placental hormones. Also, the influence of treatment modalities on the developing fetus also affects therapeutic decision making. The gold standard for diagnosis any hypothalamic pituitary endocrine disorder is contrast magnetic resonance imaging, which is contraindicated in pregnancy. These were the cases which are the challenges we faced in diagnosing the condition. Coming to management of acromegaly in pregnancy, for microadenomas, usually expecting management is followed. If it is a macroadenoma, distal field testing is also advised in every 5 years. Definite evaluation of acromegaly should be postponed until Q period due to lack of normative data on growth hormone and IGF-1 levels during gestation. Also, after delivery, MRI must be repeated in order to evaluate the tumor size. Hence, diagnosis of acromegaly in pregnancy is challenging. Treatment also is difficult depending on the effects on therapeutic decision making on the developing features also affected. So our case is unique in the fact that the patient was presented with BPC, which has not been reported previously. So my question is, thank you for giving me this opportunity.
Yeah, thank you very much for the presentation. Just wanted to ask you, the MRI you are shown was contrast MRI or
no,
non-contrast?
Non-contrast MRI. We have taken a anti-nucleation for diagnosis.
Okay, but normally contrast MRI is what is advised.
Yes, sir. But we were unable to take it in a pregnancy.
Because of the pregnancy. Okay.
Yes, sir.
Any questions and comments? Yeah. Dr. Bala, we are not able to hear you. Hello.
Hello.
Yeah, please.
Yeah. Is there any workup for hyperaldosteronism was done? Because there is hypokalemia is there. Is there any workup for hyperaldosteronism was done? Endocrine people suggested any workup for hyperaldosteronism?
Yes, sir. They asked for 24-hour urinary potassium excretion because hyperaldosteronism will have increased urinary excretion of potassium, and urinary potassium was less than normal. It is in the normal range of excretion.
Because many instances it is prudent to investigate for hyperaldosteronism that may be also coexistent. What the endocrine people suggested.
Yes, sir.
Because there is significant hypokalemia, you told. Apart from the cause for hypokalemia, the patient was not in any hyperemesis. I hope so.
No, sir. It's not audible at all. So hypoaldosteronism will have increased urinary potassium excretion rate. We have seen 24-hour urinary protein excretion, which was in the normal level, and thus hyperaldosteronism was ruled out.
Okay.
Are you able to hear me?
Fine. It's not audible for me. Okay.
Okay. Okay, if there are no further questions, thank you, Dr. Aishwarya, for the nice case report. Thank you very much.
We'll move to the next case report.
Thank
The
you.
The cancer that carried a chalk by Dr. K.S. Subramaniam from the Department of Medicine.
Good afternoon to one and all. Am I audible, sir?
Yes, your slides are visible and you are audible. You can.
Yes. Thank you, ma'am. I am Nidish Chandrayam. I am Junior Resident, Department of Medicine. First of all, I would like to thank the JSS team for giving me an opportunity to present my case report. I am from Medicine Unit 1 and our consultants are Dr. Deepak Amalnath, Dr. Mukta Vyavahare and Dr. D.K. Subramaniam. Moving on to my case report. Our patient is a 36-year-old housewife who came with complaints of generalized weakness for 1 month and swellings in both arms for 1 month and numbness over the little finger and ring finger of both hands for 1 month. There was no other history of any arthralgia, myalgia, fever or any other systemic symptoms. Past history wise, patient was treated for a carcinoma ovary which was biopsy proven and it was a mucinous cystadenocarcinoma. Patient was treated outside in December 2018. And as part of treatment for CA ovary, she underwent total abdominal hysterectomy and bilateral salpingo-oophorectomy, following which she received 6 cycles of chemotherapy with cisplatin and paclitaxel. And she completed treatment in May 2019, and she was confirmed to have having disease, no disease activity in May 2019. So now she presented to us in December 2019, last year, with complaints of generalized weakness and inability to walk. So she was referred to JIPMER as a case of recurrence of malignancy. So initially she was admitted as a case of relapsed carcinoma ovary, and initial evaluation showed PET was taken as part of initial evaluation, which showed some uptake in right lung, which was suggestive of Curie mets. And she was planned for initially palliative chemotherapy. Then the weakness worsened and patient was completely bedridden. Then the patient was transferred to our side and general examination showed that patient had swelling in the left arm, which was measuring around 9 into 5 centimeters, which was a painless swelling, which was mobile and it was moving in all directions and it was in the subcutaneous plane. And on the right arm also, patient had a similar swelling around 10 into 5 centimeters, painless swelling, mobile in all direction and painless. She had similar swellings in the abdomen also. So these are the images of the swellings. Then on general examination, she had a rash like this, and it is a very classical of a heliotrope rash, and lower limb showed a hyperpigmented lesion in the medial and the anterior thigh, which we classically called as Holster sign. This is the image of a holster. It's classically seen in the lateral aspect of the calf, whereas in our patient it was more medial and in the anterior part of the thigh. So on further examination, patient had a proximal weakness of power 1/5 in both upper limb and lower limb, and neck flow was also present. All the deep tendon reflexes were absent and bilateral plantars were flexor. And peripheral nervous system examination showed all modalities of sensations were lost along the ulnar nerve distribution in both hands, and clinical test for ulnar nerve diseases like Fromen's and Carr test was positive in both hands, and median nerve examination was unremarkable, it was normal. So our working diagnosis in a lady, in a 36-year-old with a past history of CA ovary, completely treated, now coming with proximal muscle weakness and classical skin findings of dermatomyositis, our clinical diagnosis was paraneoplastic dermatomyositis. So as a part of dermatomyositis workup, we had done a CK total, which was very high, 1046, and a myoblot was done, which showed NXP2 positivity, that is nuclear matrix protein positive, and Rho52 positive. This NXP2 is a protein which is highly suggestive of paraneoplastic dermatomyositis. And as part of workup for this swellings in the arm and the abdomen, an X-ray pelvis was done, which showed this which showed diffuse subcutaneous calcifications in the thigh as well as in the thigh as well as in the arm. So this is the image of the pelvis, which shows diffuse calcifications in the thigh and arm. And this is the X-ray of the right arm, which showed diffuse calcifications in the arm, in the subcutaneous plane. And for the workup of the relapse ovary, we had done a CECT abdomen which showed calcifications extensively in the pelvis as well as in the thigh. This is the CECT image, and this was the sagittal section which showed diffuse calcifications in the subcutaneous plane throughout from the abdomen extending till the thigh. This is the coronal section which showed classical calcinous cutis-like picture in the subcutaneous plane. So a nerve conduction study to find out the pattern of nerve involvement we had done, and that showed bilateral ulnar sensory motor neuropathy and the progress of the patient. So the patient was confirmed as having a paraneoplastic dermatomyositis based on clinical picture as well as myoblood picture, and patient was given IV immunoglobulin 2 gram per kilogram over 5 days, and weakness started to improve after 1 week of IVIG. So our final diagnosis was mucinous cystadenoma carcinoma ovary and paraneoplastic dermatomyositis with diffuse calcinosis cutis and bilateral ulnar sensory motor neuropathy. So the outcome of the patient at present, now the power has improved to 4/5 in both limbs. Patient is now ambulatory. The ulnar neuropathy was managed conservatively with amitriptyline. Calcinosis cutis, however, is still persisting, and review imaging done after 6 months showed no residual ovarian lesion or no evidence of any metastasis. So the take-home message in this case is dermatomyositis can rarely lead to calcinosis cutis. The mechanism is a dystrophic calcification, and dermatomyositis can have peripheral nerve involvement, and the mechanism proposed is a neuromyositis, which is an extra muscular manifestation of dermatomyositis, and our case represents a late and rare presentation of paraneoplastic dermatomyositis after a successful treatment of primary ovarian cancer. Moving on to the discussion, 2 important points. First one is calcinosis cutis in dermatomyositis. Calcinosis cutis itself is a rare manifestation of dermatomyositis. The calcification in dermatomyositis is mainly dystrophic calcification with normal serum calcium and phosphorus. Our patient also had normal serum calcium and phosphorus. Though several theories have been associated with dystrophic calcification, the most important is associated with damaged, inflamed or necrotic skin. Now coming on to nerve involvement in dermatomyositis, concomitant involvement of peripheral nervous system in dermatomyositis was first introduced by Senator in 1893. Peripheral neuropathy is an important extramuscular manifestation in patients with dermatomyositis. However, in our scenario, we usually don't come across with peripheral neuropathy in the case of dermatomyositis. So still the association between inflammatory myopathy and peripheral neuropathy is unclear and controversial. So further studies are needed to elucidate the relationship between dermatomyositis and peripheral neuropathy. Thank you.
Thank you for the interesting case report. Is there any reason why the dystrophic calcification is not affecting the other parts apart from skin?
Yes, sir. Actually, the mechanisms which they propose for dystrophic calcification is where there is increased inflammation and where there is more skin damage. So this patient, when the patient came, the patient had generalized anasarca, which was more in the abdominal region as well as in the arm region. So that the area there must have been more inflamed or damaged. That must have been the reason why the patient must have had more calcification there, sir.
Dr. DK, sir, you want to comment in? Please unmute.
Yeah, actually, this case was presented for that beautiful pictures of calcification. It was, I had seen this once before, maybe 10-15 years back, the second case. So I thought we should share those images for the others also. I don't know, the immunologist may be in a better position to tell whether this is quite common, but literature say all case reports. There are not no collections of cases which have been reported. So it must be very rare. Percentage also are not documented. What percentage have this sort of calcification? As far as my search is concerned, maybe incomplete. So I thought we'll share those images and the story of that patient, the way she went about, came for carcinoma ovary, then paraneoplastic. Now she's doing well. That's the good end of the story.
Thank you, sir. Are there any other comments or suggestions?
One, sir. Nitish?
Yes, sir.
Did you do any nerve conduction study to confirm the ulnar neuropathy? You told that that is a neuromyositis is there. Whether
Yes,
nerve
sir.
conduction study was done?
Yes, sir. Nerve conduction study was done, which showed decrease in both amplitude as well as velocity in both hands, sir. Suggestive of an ulnar neuropathy in both hands.
You didn't tell that in the presentation. That is the reason I asked.
Yes, sir. It was put there, sir. NCS was report was put there, sir. In the
okay, fine.
Yes, thank you, sir.
There are no further questions. Thank you very much for the very interesting case report and the excellent images. Thank you very much.
Thank you, sir. Thank you.
We move on to the third case presentation for the day. This is a fatal case of wasp envenomation in a non-morbid individual by Dr. Ambika Prasad and Dr. T. Nadia from Department of Forensic Medicine and Toxicology. Dr. Nadia will be presenting.
Good afternoon. Can you hear me, sir?
Yeah, please proceed. Your slides are visible. Yeah, please start your presentation.
Good afternoon. I'm going to present a case on fatal case of wasp envenomation in a non-morbid individual. And myself, Dr. Nitya, junior resident, and my moderator is Dr. Ambika Prasad Patra from Department of Forensic Medicine and Toxicology. Usually, wasp or bee envenomation are not fatal unless pre-existing morbidity is there. But there is significant increased burden of morbidity and mortality from bee and wasp sting as depicted in figure 1, which shows during the period of 2000 to 2011, a total of 1,109 cases of mortality due to wasp, bee, and hornet stings, of which 43 deaths in 2001 minimum and a maximum of 89 deaths in 2017 was reported. Among the Hymenoptera insects, which include Apidae, which is bees, Vespidae, wasps, and hornets, Formicidae ants, the most common stinging insects are bees and wasps, and the most common immune reaction are due to wasp stings than bees. So the wasps can sting repeatedly without losing sting apparatus, and they inject around 2 to 15 micrograms. The sensitization reaction to wasp venom can occur even after a single sting. And the symptoms are mainly due to allergic reaction and not due to venom per se. Symptoms of wasp sting can be classified into 3, that is immediate local reaction, allergic reaction, and late reactions. So the allergic reaction can be early reaction, which is tingling sensation of scalp flushing, dizziness, visual disturbance.
Your slides are not moving actually. We are still on the first slide.
Can you see now, sir?
No.
Now, sir? Can you see now, sir?
Now it is okay. Please proceed.
So the symptoms of allergic reaction can be of early symptoms like tingling sensation of scalp flushing, dizziness, visual disturbances, and GI symptoms like nausea and vomiting. And delayed reaction include urticaria, rash, pedal edema, arthritis, and serum sickness like syndromes. It can also cause systemic symptoms, which can be direct and indirect cytotoxic symptoms, which involves liver, renal, and myocyte membrane. Hemolytic, neurotoxic, and vasoactive properties are also present in wasp sting, which can lead to intravascular hemolysis and rhabdomyolysis. So I'm going to present this rare case of fatal wasp sting caused due to anaphylaxis. The case report is a 47-year-old male engaged in agricultural work. He was suddenly stung by a swarm of wasps, and he was shifted to our hospital within an hour and admitted to the emergency department. Complaints of swelling of face and stridor was present. On examination, pulse was weak and blood pressure not recordable. Respiratory rate was 30 per minute, accompanied with wheeze and stridor. Glasgow Coma Scale was 3. On examination of womb, no evidence of stinger was present. and no previous history of comorbidities was present, and there was also no history of peer sensitization. He was treated with injection hydrocortisone, noradrenaline, calcium gluconate, and dobutamine. Despite all supportive measures, he was succumbed to death within 4 hours. A medical legal case was registered and the body was sent for autopsy. So on performing autopsy, external examination showed swelling and congestion of eyelid, face, mouth, and tongue. Serosanguinous fluid was oozing from nostrils and mouth. Multiple puncture marks without stricture on over face, upper chest, and both upper limbs were present, with a dimension of 0.1 centimeter, and swelling and congestion and hemorrhage was present. On dissection, focal subendocardial hemorrhage in both the ventricles was present, as shown in the image, and moderate edema and congestion of larynx, trachea, and lungs was present. Pleural cavity contained 300 ml of serosanguinous fluid. Lungs and brain showed congestion and edema. Other abdominal organs were intact and unremarkable. Chemical analysis and histopathological examination was done, and chemical analysis was negative, and it has not shown any alcohol also. Tryptase level was not estimated because of unavailability in our hospital. Histopathological examination showed subepithelial edema of the larynx. Immunological study was done, which showed increase in venom-specific serum IgE levels and decreased complement C3 levels. So, on perusal of all the hospital records available, the cause of death was concluded as anaphylactic shock due to multiple wasp envenomation. This is the histopathological image we have obtained, which showed subepithelial edema of larynx. Coming to discussion, allergic reaction to immunotherapy groups are common among men and particularly among those over 30 years. Wasp venom contain antigen 5, while phospholipase A2 is present in bee venom. Chemically, wasp venom contain mixture of complex chemicals that can break down cell membrane and neurotransmitters like acetylcholine and serotonin. They have substances that trigger the release of histamine, producing an intense allergy-like reaction. The role of complement C3 activation could be the first in vitro variable which correlate with the severity of wasting anaphylactic reaction. Das et al. Reported a case of fatal wasting with pre-existing undiagnosed diabetes and hypertension. Richard and Robert studied postmortem findings in all anaphylactic reactions and examined 56 cases, of which 19 were due to wasp and bee, and concluded that most common reported finding is non-specific pulmonary edema and congestion. Features suggesting anaphylaxis were noted in 100% of cases in food allergy and in 67% in wasp and bee venom. Pratish et al. Reported a case of wasting with unusual fatal outcome, disseminated intravascular coagulation, rhabdomyolysis with acute renal failure, secondary to wasp envenomation. Rabindranath Das et al. Reported wasp envenomation with acute renal failure, and Seong et al. Reported out of 1,091 cases admitted, 48 died due to organ injury following toxic reaction to sting, and 6 died due to anaphylactic shock. So my conclusion is, wasting can be fatal in healthy individuals with raised venom-specific IgE levels and decreased complement C3A levels. Early diagnosis using the above said blood investigation may be of great help to start early and specific treatment, especially in anaphylaxis. Venom-specific IgE are recommended for the confirmation of wasting. Hence, all such cases should be watched early for immediate hypersensitivity reaction, despite the presence or absence of comorbidities. This may help in counseling the patient regarding severe reaction and subsequent bite and take necessary precaution. These are my references. Thank you.
Thank you very much for the presentation. What are the interval between the envenomation and the death?
4 hours, sir.
4?
4 hours. 4 hours.
4 hours. Okay. Are there any other questions or points to discuss?
Sorry, I missed the initial part. A patient was brought dead, or patient was admitted in the hospital?
Initially, he was brought within 1 hour of developing symptoms. He was brought to a hospital EMS, and within 4 hours of treatment, he expired.
Oh, that's a bit unfortunate. No, what is the mortality? Most of the time we see in movies only people lying on the field, frothing from the mouth and dying. But those who reached the hospital, I remember Dr. Hamid had some publications on wasp and myocarditis, wasp and interstitial nephritis. So once, so he died after coming to the hospital. Okay. But you could have quoted Dr. Hamid's references.
The reason why I've presented this case is without the presence of any comorbidities and without any specific organ involvement, the person has expired. Only per se due to anaphylaxis.
Yeah, that is documented. That is correct, but that is no, that is not unknown. Those
Sir,
but it can occur in anyone. And I just wanted most of our experience is we salvage them. We don't have any problem.
Okay.
And I thought you should have quoted Dr. Hamid's references, also some other Das et al. You quoted. We have to quote each other.
Okay.
Otherwise, we will not.
Yes.
Sir. Thank you. Nice presentation.
Thank you.
Sir, just one question. Sir, is it audible?
Yeah, audible. Please continue.
Sir, that that presenter actually you showed that cardiac hemorrhages. So,
yes,
what could be the means possible mechanism? Actually, you told the patient died because of low C3, means immunological mediated anaphylactic.
Yes,
what could be the possible mechanism? Means you told the picture you have shown is that hemorrhage in the cardiac region. I think in autopsy.
Yes, sir. Yes, sir.
Can you tell what could be the cause for the hemorrhage in that thing? Because usually that is like, the stress cardiomyopathy occurs in the scorpion venom is different. I don't know whether it occurs with the VASP also. But you showed some hemorrhages in the autopsy of that heart, isn't it? Myocardium.
Yes, sir. Yes, sir.
Can you explain why the hemorrhage occurred? What could be the reason? Possible mechanism?
Sir, I'm not very sure of that, sir. Sorry, sir.
No, because that picture was very catchy. That is the reason I'm asking. Because the anaphylactic shock is one thing that whatever you told, Ig levels increase, then C3 levels low, complement level, all those things contributing. Because the patient died also very rapidly. The fatal this VASP thing. Okay, that is the reason.
Yes,
so you can, I think, go through. Fine.
Yes,
okay.
Yes.
Otherwise, nice presentation.
Thank you.
If there are no further questions, I will go to thank you very much, Dr. Nitya, for the very interesting case.
Thank you, sir.
Thank you very much.
We'll move on to the last presentation for the day. An interesting tale of 4 family members who consumed a unique food item by Dr. Chandini Chandramouli from the Department of Medicine.
Good evening to you all. Am I audible, sir?
Yes, you're audible and slides are also visible, so you can proceed with the presentation.
Thank you. I thank you for this opportunity to be able to present this case in JSS. It's titled An Interesting Tale of 4 Family Members Who Consumed a Unique Food Item. And this case was seen in the Department of Medicine under Unit 6. 4 family members from Virupuram presented with symptoms of vomiting and epigastric pain 6 hours after, which was present for 6 hours, and the symptoms started half an hour after consumption of homemade sweets which were prepared from kodo millet grains. This is locally known as varagu, and it was mixed with jaggery. The millets had been stored for more than 1 year after having been cultivated on the family's field. And apart from the vomiting and abdominal discomfort, 2 of the family members also developed tremulousness and involuntary movements of all 4 limbs. These are the clinical features when we saw these patients. As you can see, all the 4 patients had, 2 of the patients had bradycardia, whereas the other 2 patients had a borderline low pulse rate. And the first 2 patients also had mild hypertension. And one of the patients had a grossly elevated BP of 170/80. In the first 2 patients, abnormal movements were present, the videos of which I'll be showing shortly. And in all 4 patients, we were able to see the ECG changes of prolonged QT interval and sinus bradycardia in the first 2 patients. 1 out of the 4 patients also had hypomagnesemia, whereas the electrolyte analysis of all the other patients was normal for all the remaining electrolytes. So this is a video demonstrating the abnormal movements. As we can see, there are head tremors of the 68-year-old female, as well as once she raises her hands, we can see coarse tremors, which involve the upper limbs, the proximal as well as distal aspect of the upper limbs. In this 42-year-old male who also had abnormal movements, we see that there are coarse tremors of low frequency and large amplitude, including both the lower extremity as well as the upper extremity, more distal than proximal in the upper limbs. These movements were partially suppressible when the patient attempted to hide them. Now coming to the ECGs of all 4 patients, as you can see, there is a prolonged QT interval as well as bradycardia in the first 2 patients, as well as prolonged QT interval and 1 patient with a borderline prolonged QT interval in the other 2 ECGs. So what exactly were we dealing with here? As all 4 patients presented with a similar toxidrome, also around the same time after consumption of a common food item with no other obvious cause, we felt compelled to ascribe it to the kodo millet itself. Now, this is a picture of the kodo millet grains, which was brought to us by the family in this packet, as well as a picture of the sweets prepared from them. This is ground raw millets, and they are mixed with jaggery. On reviewing the literature, we found a case report way back from 1949, which was published in Nature, and rather boldly in Tamil itself, it was titled as Varugu poisoning. This was way back in 1949 when there was a shortage of rice, and the ration shops were compulsorily selling millets on a large scale as a substitute. So in the Madras presidency, as we can see here, a number of patients presented with a toxidrome which was similar to the 4 patients that we had seen, and all cases resolved spontaneously. So coming to the pathophysiology of kodo millet poisoning, kodo millets have been reported to be infested with Aspergillus species as well as Penicillium, and the common species of Aspergillus are Flavus, Tamaria, and versicolor. Now, on seeing the literature, we found that these fungi have the ability to produce a mycotoxin, which is known as cyclopyrazonic acid, or CPA. The molecular pathogenesis of this toxin is that it's an inhibitor of the sarcoplasmic reticulum calcium ATPase subtype 1A, which is circa is found in 3 isoforms, the type 1 and type 2 being more prominent in the skeletal muscle, whereas type 3 is found more in cardiac muscle. But 1A is found in both skeletal and cardiac muscle, and CPA is also a chelator of divalent ions like calcium and magnesium, which is an important mechanism of its toxicity, and it could also explain the hypomagnesemia that we observed in 1 patient along with the ECG changes. So contaminated kodo millet consumption has been reported mostly in animals, which is why this case is so rare. And due to the ability of this CPA to produce abnormal movements, it has been described in literature as a fungal tremogen, among other fungal mycotoxins, which have mainly been reported in animals. Now, kodo millets, also it is important to note that apart from the fungal infestation, the kodo millets themselves contain small amounts of CPA, which when consumed in large amounts can be toxigenic. They produce a syndrome of gastrointestinal complaints with neurological manifestations ranging from tremors to paralysis to drowsiness, and autonomic changes, as well as hepatotoxicity, which has been observed in animals. Along with these manifestations which we had in our patients, the novel manifestations that we noted were prolonged QT interval in all 4 patients and hypomagnesemia in 1 patient. All the 4 patients were treated symptomatically. The magnesium level of that 1 patient was corrected, and they all improved within 24 hours. Although we attempted to confirm the diagnosis by sending the sweets as well as the whole millet seeds for toxin analysis, both locally in Pondicherry as well as after contacting CFTRI in Mysore, due to logistic issues during the pandemic, it could not be performed. We also attempted a fungal culture on the millet seeds, but this did not show any growth. So millets are making a comeback in the Indian diet because they're being promoted as a fiber-rich substitute to rice in many Indian cuisines as well as in the diabetic diet. It's important to educate people regarding safe methods of storage of millets, and because CPA is a heat labile toxin, cooking also neutralizes the toxin and prevents this poisoning. Therefore, our case is rare and unique because it has reported a rare toxidrome of a unique food grain with newly reported manifestations of ECG changes and hypomagnesemia, along with prominent neuromuscular manifestations. These are my references. Thank you for your time.
Thank you very much for the very interesting case report, and I think it's worth publishing, especially to remind people about its implication. Are there any questions or comments?
Have you got any images of that millet?
Sorry, ma'am, I can't hear you.
No, have you got any images of that particular millet, the Varagu millet?
Yes, ma'am. I showed it in the. I'll go back to that.
No, the raw millet you're asking? Yeah. Raw
Yes, ma'am.
millet.
Yes, ma'am.
That's the raw millet, sir.
This is the raw millet, ma'am.
That's the raw one, huh?
This is the raw one, and this is the sweet that they had prepared from it.
Okay,
This is the form in which it is stored. That it is sold in all the department stores.
It's in a bag, correct?
Yes, yes, sir.
Yeah, yeah.
Look
Okay.
more like a dish.
Yeah, it's in a bag. Okay, got it. Yeah. Okay.
It's in a bag, sir.
Yeah, okay.
Is it commonly sold or something?
Yes, ma'am. It's available even locally here. It's available. There are many types of millets, of course, and this is just one type of them. Kodo millet being the specific name.
So this fungal infection is not particularly confined to this. It can affect any millet.
Yes, ma'am. It has been found it has been described only in Kodo millets, and that can be partially ascribed to the fact that, as I alluded to, CPA is present both within the Kodo millet grain itself as well as the fungal infestations. And many of the case reports could not delineate whether it was a property of the millet itself or the fungus, but it has been isolated, Aspergillus has been isolated. Regardless, this kind of infestation with CPA toxicity can be seen in European case reports. It has been reported in soft cheeses, as well as in poultry. Farmers have reported it in cases of birds when they have mixed it in the poultry feed.
Are there any questions or comments or suggestions?
Sir?
Yeah, please.
So basically, that all these millets, like that bajra and then sorghum and all those things, because there is a re-emergence of consumption among the urban population, because they tell that these millets are healthier, and because with the low glycemic index and all those things. Particularly, like Chandani mentioned, because that this food is being prepared rawly, because they choked in a water and then they grind it. Basically, if you cook properly, and then that cyclopyogenic will be neutralized. That is the thing we have to educate the public also, because this varagu predominantly it is available in the southern India, particularly in Tamil Nadu and other parts of the area. Like what Madam asked, this is commercially available in the supermarkets in the name of varagu, but because many people might not be knowing the kodo millet or that Paspalum scrobiculotum, because in human beings, means in a human being, it is very, very rarely reported, except that 1949 case report by that Narayanasamy Iyer. Nobody has reported. All other things are in the cattle and animals. That is the reason it produces the classical manifestation. Apart from that, we are able to find out hypomagnesemia also based on the pathophysiology. So we have to make a point that we have to educate the public. When the food is being stored for a longer time, it tends to get fungal infested. That is the point we have to educate the rural population particularly. That is the reason that case is being presented. That's all.
Okay. If there are no further questions or comments, thank you very much for the very interesting case report. Thank you very much. So with this, we conclude today's JSS talk. On behalf of JSS, we sincerely thank all the presenters and their scientific contributions, and all the sponsoring faculty for these papers. And thank you very much, and we'll close this session.